It is an honor and privilege to be serving our nation, and also an honor and privilege to be here this evening. So I am a self-proclaimed precision oncologist. I head the Medical and Precision Oncology Division at Sir H.N. Reliance Foundation Hospital, and I also head the translational and clinical research at the center. I have a for-profit undertaking called Nova Precision AI, with which we do consultations for precision internationally for tough cases. And I also am the vice chair of World Innovative Network in Precision Medicine as of last year. My journey in precision actually started through my time in the US, and I'm going to elaborate on some of that story and how it totally blends into the precision oncology story of breast cancer as well. These are my disclaimers. When we look at cancer, we know cancer is an epidemic. 1 in 2 men and 1 in 3 women will be affected by cancer in their lifetime. Cancer is a global burden, but for India, it is certainly a pressing epidemic. And when we look at the rates of mortality, there is a need for a game changer. This is a borrowed slide from my presentation at UN General Assembly in 2024, and my pitch was to follow a hub and spoke model, and that begins from the left lower bars that you see. The red bars of cancer care are showing 80% of cancer care happens out of pocket. Only 20% can be covered by insurance. This is the Indian story. And when you look at the number of clinical trials as of 2023 and 2024, only 400 clinical trials serving 1.5 billion population in India, and that's a true heartache. When we look at how India can be served, we always look up to Tata Memorial Hospital, and we always look up to leading institutions like AIIMS, Tata Memorial Hospital, other academic centers like GCRI. But what we really have to come up and understand and accept and take the responsibility for is all of us working in private centers and corporates should also hold responsibility, feel responsible, and help propagate the message of cancer care in community. And I know we all are doing that, but my pitch is that precision is that tool with which we can serve in a resource limited setting. We can serve the nation in the best possible way by selecting for higher outcomes, by knowing the pathways that are driving that cancer. As an oncologist, one of the biggest challenges we have is we have the job at hand. So we see a patient walking in that we have to then quickly scramble up, diagnose and treat. That's our primary responsibility. That is your responsibility as a treating clinician. We hardly have any time to think about screening and prevention. And that's where we have to mobilize ourselves, mobilize our population to do this in parallel with what we do as a service. When we look at precision and the way precision is practiced, it is an old concept. It is just this thought of right drug to the right patient, right cost at right time, but every time. It is a concept that as old as blood transfusions. It's a concept that is as old as ER-positive breast cancer getting hormonal therapy. And that's where I bring us back to precision in breast cancer and how it is actually a breast cancer story. The idea is to enhance survival. What do we have today? We have the green curve where we say tail of the tail with immunotherapy, and 20% of patients that get exposed to immunotherapy will live on forever. But the idea with precision is to raise the bar to 90%. And actually, my journey in precision in India started 10 years ago when I came back from the US, and I already feel my slides are completely dated, that precision is already an old concept. We look at the precision journey and we look at the number of drugs, both targeted therapy, hormone therapy, immunotherapy that has come about. And now we are moving into a era of ADCs, antibody drug conjugates. We are also moving into the era of cellular therapeutics, where actually even biomarkers are getting trumped. We don't have association of TROP2 expression and the TROP2 inhibitors like sacituzumab, Dato-DXd, sacituzumab tirumutican, all of these are active irrespective of the TROP2 level. We have to figure out what would be the most cost-effective way of bringing these drugs into the therapy for patients. There's also the role of AI coming in putting the data of genomic analysis together in application in service of the patient. And I think this field of utilization of precision is only going to grow once AI makes the delivery of precision a cookie cutter, a routine thing in our clinics, where your computer would then be guiding you once this genomic report is done, this is the therapy for the patient. And then we would be able to spend our time in serving the patient much more than we are able to do today, while we are studying the reports and understanding and orienting ourselves to the genomics of the patient. When we say precision is winning the war against cancer, is it time? I woke up to this article this morning, and this tweet this morning, and actually the boy in that picture is my kid brother, Dr. Aditya Srinivas, and they talk about the different expressions of HER2 in this article. They talk about the newer ADCs with biomarker-driven approach. We know that HER2 positivity as amplification is seen in 20 to 30% of breast cancers, but we all know that Dato-DXd, N-HER2, trastuzumab deruxtecan as a drug, TDXD is a drug that now is applicable to HER2 positivity by IHC. So HER2 3+, 2+, 1+, and even for 0, we know ultra low HER2 is something that can be treated with N-HER2 and it will work. The idea is to bring biomarker-driven therapy up, and up at the earliest. And this is the pitch that is happening here by Professor Rachel Kurzrock, who is the queen of precision medicine. And Ray says here that you have to bring in biomarker-driven therapy up front as early as possible, even before the tumors actually educate themselves to resistance and to non-functioning chemotherapy. How did I get my precision orientation? My story goes back to my days as a junior faculty at Harvard University. This is early 2000s, and I can tell you that I was as ignorant to precision as anyone else. We happened to open a clinical trial that was funded by NCI, National Cancer Institute, and NIH. It was a trial with 40 genes called OncoPanel, and a head and neck patient who had metastatic disease actually tested positive for HER2. This is Ali Ali. Ali Ali had advanced metastatic, heavily pre-treated state of head and neck, and he was found to be positive with a HER2 amplification for which we then ended up utilizing a breast cancer drug to treat his condition. We were featured together as a doctor-patient duo in Paths to Progress from Dana-Farber Cancer Center, one of the books that they would release on a monthly level. When we treated Ali with trastuzumab plus chemotherapy, his disease went away. This left a lasting memory in my mind, and then studied many different cancers, including a very rare type of head and neck cancer called salivary duct cancer. And here we demonstrated that 20 to 30% of salivary duct cancers are also HER2 positive. And when treated with a breast cancer drug, you can actually change the outcome. You can transform the outcome for these patients. And they responded. Even when metastatic, they responded. I brought this story with me and hence treated many, many patients with this concept and published here even from India. These are different malignancies that have been treated with this concept, but the HER2 story stayed with me. It actually began when I was a junior intern at New York University way back in early 2000s. And my biggest project, my first project, was a data collection on 2,000 metastatic breast cancer patients at Sloan Kettering Cancer Center. They were all HER2 positive. That was my orientation to pathways. And it all started with breast cancer. And I saw that these metastatic breast cancer patients who were HER2 positive, when given a transforming drug called trastuzumab, which was just discovered by Professor Jose Baselga, changed the outcome of the disease melted away, these metastatic patients would respond to HER2-directed therapy and go into remission. I, as a junior intern, was documenting patient after patient the responses, the magical responses that appeared as an outlier. It was only when I became a faculty and I could look back into the HER2 story that I realized that this was the pathway across different cancer types that was actually holding the story true. Fast forward to some of my breast cancer cases, because here we are talking breast cancer. This is a patient that is 72-year-old, HR positive, so hormone positive metastatic breast cancer, failure on first-line therapy for advanced disease, abemaciclib, which is a CDK4/6 inhibitor, and letrozole. And you can just see a picture's worth 1,000 words. You can see she has more than 1,000 lesions in her body through the PET scan. And on profiling, genomic profiling, she was found to have a HER2 mutation. So when we look at the profile, we always go to one of the best pathways. And in this situation, we found the HER2 pathway here for this patient, and we treated this patient with TDM1, which is Kadcyla, which is again a HER2-directed ADC. Another patient, you can see the liver is replaced by disease, and again this patient had hormone-positive breast cancer treated with abemaciclib, letrozole, Zoladex, just a 37-year-old. Later on treated with capivasertib, abemaciclib, letrozole. The INAVO trial happened later. We treated this patient earlier, and the PIK3CA mutation, which homes into the breast. And look at the breast, and look at the scan, and the date of the scan. This is 2021, and this is 2026. This patient lives on as if nothing happened to her. Another patient with HR positive MBC, failure on abema, letrozole. And here again, this patient was BRCA positive. This patient is treated with olaparib and letrozole, and the disease completely gone. We have a triple-negative breast cancer patient that had EGFR amplification, heavily pretreated, beyond chemotherapy, beyond immunotherapy, several lines of treatment. This is a case that we are publishing, EGFR amplification, and 2 EGFR drugs for this patient. And you can see 2023 and 2026. Sorry, give me 2 minutes. This is triple-negative breast cancer. And you can see she has more than 20 lesions in her lung and complete response with pembrolizumab, failed therapy, found to have EGFR amplification, treated with erlotinib, and complete remission. Here again, ERBB2 mutation, complete disappearance with TDXD. Multi-pathway therapy, because cancer is an ever-evolving disease, and you have to consider multi-pathway multiple times. I follow the iPredict trial. I follow the Resilient trial that was run in India. I follow Exacta-guided therapy, which is a multi-pathway functional analysis with chemosensitivity. Here is a graphic image of a head and neck patient. There's published data here for multiple Exactas done on different body fluids and tissue in a breast cancer patient. The method of treating is called N of 1. Every patient, you give personalized treatment. I'm going to scoot over. There's another Exacta patient in the breast cancer. I'm just going to finish because I think I'm going to run late otherwise. Liquid biopsy is something that I use all the time. And now liquid biopsy is being utilized for screening. And of course, we are coming to cell therapy, which is the most personalized way of treating a patient. We are working on something called PercyVax, which is a cell lysate vaccine. I have a patient with TILS therapy in triple-negative breast cancer, which is working on the patient microenvironment, the tumor microenvironment, and an overarching goal to develop a biotech park for precision oncology program. This is my humble abode, the Precision Oncology Center at Reliance Foundation Hospital, where we don't just practice precision clinic with consultations and molecular tumor boards and multidisciplinary tumor boards, but we also engage in precision cancer prevention. And that's the dhurandhar of my team. And we launched the Patient Advocacy Alliance and Clinical Trial Consortium at this Illuminate 3.0. And finally, these are my collaborators. My deepest gratitude to our chairperson, Srimati Neeta Mukesh Ambani, Madam, and all other collaborators who have made my journey fruitful. I'm humbled by my presence here today. Thank you so much for a patient listening. I'm hoping I left you with a message for precision oncology in breast cancer. Thank you so much. I think I'm already out of time, so I will have to skip questions, I guess.
Yeah. We can invite some few questions.
Very inspiring and very interesting presentation.
Thank you.
My question is, at this point of time, do we have any reliable biomarkers for the stage of prevention or early detection in breast?
So if you will allow me to go back on my slide, I just want to share one slide. Different into the era of early detections. They are called multi-cancer early detection, the MCED tests. And so this is the Annals of Internal Medicine that has done a review where they've published that these 20 liquid biopsies are actually available for commercial use. One test that is in that publication that is in India is Datar's TrueCheck Intelli that checks for 70 different epithelial malignancies in blood. I remember I am one of their lead researchers, and I'm also the lead researcher for Strand Life Sciences, which has launched its cancer spot. Strand is 80% owned by Reliance. And so both Datar and Strand are homegrown Indian companies that are actually ready for prime time with liquid biopsies that are available commercially. This is for breast cancer.
Thank you.
Nice presentation by Lima ma'am. Just one question. that you have nicely presented the biomarkers in precision diagnostic in breast carcinoma. But in that area where these genomic markers or biomarkers are not available, in that area, how can we reach to this diagnosis?
So that's
because
great.
because our India, just like Bihar or some maximum part of India is not up to the level of Mumbai. So in that condition, how can reach to this precision diagnosis?
I think, so 2 points you've touched. One point is in breast cancer where you don't have a biomarker. And secondly, the lack of resources for biomarker testing. So I feel that there is a core movement needed. And the movement has to be at a government level. I was struck down this morning when I was moderating a session in Bodh Gaya, where I was told it's not government's responsibility and that corporates should take responsibility. Of course, corporates should take responsibility. But I think people like all of us out here need to come together to pitch to the government to not just include biomarker testing for advanced cancers, but also look at biomarker testing for early diagnosis, for cancer detection, and utilize biomarker testing as a screening method. Now, why should we do that? Only one reason. We are a resource-limited nation. In that, if there is a biomarker that is going to transform the outcome for a patient, especially a stage 4 patient, should we not know that at the doorstep? I feel ये वो हर पेशेंट का हक है कि उसका बायोमार्कर दरवाजे पे टेस्ट किया जाए और पता किया जाए कि वो उस 20%, 40% में है कि नहीं, जहां उसकी जिंदगी बहुत लंबी चली जाएगी अगर उसको टारगेटेड थेरेपी दिया जाए तो. And I think I'm an activist more than a clinician, right? नेता बन सकती हूँ.
Thank you, ma'am. Thank you.
Thank you.
Now we
Thank you
conclude
so
this
much.
session.
Thank you.
Thanks, Lima ma'am. Thanks for nice presentation again. Thank you.
It has to be standardized, and think we can give a lot of help to the needy patients. I think, Sevanti, I will appreciate your version that government should come forward, where we can.
By Dr. Sevanti ma'am. Thank you very much. A special thanks to our chairpersons. It's time to photo sessions. Kindly come forward. Our chairperson. It's time for lamp lighting ceremony. And to conduct this session, I would like to invite on the stage Dr. Rahul Chaudhary sir, co-chairman, to proceed for inaugural ceremony. Ladies and gentlemen, जोरदार तालियों से स्वागत कीजिए.
Good evening, everybody. It is indeed a privilege to welcome you all to this CME on breast cancer surgery organized by the Bihar Breast Group under the aegis of ABSI. When we begin our journey in medicine and surgery, learning is often driven by curiosity and desire. The desire to understand the disease better, the desire to refine our skills, and the desire to master the art and science of surgery. But as the years pass by, that desire transforms into something deeper, a responsibility to continuously improve ourselves so that we can offer the very best care to the patients who place their trust in us. The field of medical sciences is constantly evolving. New technologies, new surgical techniques, and newer concepts continue to emerge at a remarkable pace. What may seem unfamiliar or even challenging today often becomes the accepted standard of care tomorrow. In many ways, today's new sense becomes tomorrow's common sense. This was taken by my professor, actually. He had mentioned this when I was a student in MBBS. Therefore, Staying updated is not merely desirable, it is essential. While technology and connectivity have reduced the barriers to accessing knowledge, true progress comes from structured learning, hands-on training, and meaningful academic exchange. It is imperative that before we adopt new techniques in our practice, we train ourselves adequately to understand them thoroughly, because our patients are not experiments. They are real people whose lives and hopes are entrusted to our care. It is with this spirit that the CME has been organized, to create a platform where experienced faculty and young surgeons can come together, share their expertise, discuss evolving concepts in breast cancer surgery, and collectively enhance the standards of care. Savera Cancer Hospital, one of the leading cancer centers in Patna, has always believed in promoting academic activity and collaborative learning. We have organized similar programs in the past and remain committed to continuing such initiatives for the growth of the surgical community and ultimately for improving cancer care for the people of Bihar. We are extremely fortunate today to have with us a distinguished group of faculty members and dignitaries who have graciously spared their valuable time to share their knowledge and guide us. It is therefore a privilege to begin the inaugural ceremony with the felicitation of our patrons and co-patrons. May I request Dr. Pritanjali ma'am to kindly present a bouquet to Padmashree Sir Dr. J.K. Singh. It's a plant. So, Dr. J.K. Singh sir, whose contribution to cancer care in Bihar has been immense. I would request Dr. Shambhavi, ma'am, please present a plant to Padmashree sir, Dr. R.N. Singh, one of the most respected orthopedic surgeons of Bihar. Sir, it is a privilege to have you with us today, sir. Dr. Shambhavi. Dr. Shambhavi, please again present a plant to Padmashree Dr. Shanti Roy, eminent gynecologist and highly respected member of the medical fraternity. Dr. Amrita, I would request Dr. Amrita to present the plant to Dr. B. Sanyal, Director, Mahavir Cancer Sanstha. Dr. Tanushree, please come forward. I would request you to present a plant to Dr. Narendra Singh, Principal, PMCH. Dr. Anita, ma'am, please come forward. Dr. Anita, please present a plant to Dr. Manish Mandal, Medical Superintendent, IGIMS. Dr. VP Singh, sir, please present a bouquet, please present a plant to the President-elect, Dr. Navneet Kaur, President-elect, ABSI. Okay, she'll be joining us later. Okay, with the felicitation ceremony concluded, may I now request our esteemed dignitaries to kindly come forward for the ceremonial lighting of the lamp. Sir, please come forward, sir. Sir, Dr. Sanyal, sir. Sir, Singh, sir. So please, sir, come forward. Dr. Pritanjali, please come forward. Dr. Diptender, sir, please come forward for lighting the lamps. Sir, Dr. Amar Deshpande, sir, please come forward, sir. Dr. Shalakha, please join in. Dr. Arunima, please join in. Dr. Rishikesh Parmeshwar, please. The lighting of the lamp has always symbolized the illumination of knowledge, wisdom, and learning, values that lie at the very heart of medicine and academic exchange.
आइए चलते हैं अज्ञान से ज्ञान की ओर। धरती से आकाश की ओर, पदार्थ से सूक्ष्म की ओर, नकारात्मक से सकारात्मक की ओर।
Thank you, esteemed dignitaries. May I request you all to kindly stay for a group photograph. I would also request the office bearers to please join in for the same.
Thank you, dignitaries. May the lights of knowledge guide us in our endeavor, conquer breast cancer.
May I request the office bearers to please take the stage. Dr. VP Singh sir, Dr. PK Jha, Dr. Manish Kumar, IGIMS, Dr. Pradeep Jaiswal, Dr. Prashant Kumar, AIIMS, Patna, Dr. Akash Kumar Singh, the Organizing Secretary, and President-elect ABSI, Dr. Navneet Kaur, please come on the dais. It is now my privilege to invite Dr. VP Singh, Organizing Chairman, Senior Surgical Oncologist, and Director of Savera Cancer Hospital, to deliver the welcome address. So please.
A very good evening to all of you. It's well said, well begun is half done. And practically, that's what we have been doing since morning. This ABSI SKILLCON is nothing but a surgical academic feast. Now, in the morning, we had all the surgical work. Now, it's a blend of surgery, radiation, and definitely a medical oncology. So, cancer treatment cannot be complete without a unit, without a team. So, you have to have a team to deliver the best possible treatment to a person. And ABSI has been doing this since almost a decade in this field of breast cancer. Rather breast diseases, I will call it as. So ever since the formation, at the foundation, I've been associated with ABSI, and one of the founder members, we find quite a lot of founder members here. Dr. Diptendra is there, Amar is there, Rishikesh is there. They all are founder members of ABSI. And since the inception, we have been striving hard to spread this message of breast disease and how best we can capitalize on the foundation, how best the teaching program can be extrapolated across India, not only across India, across the border as well. We have been doing it. And we have been quite successful in almost all the events which we have been doing. You'll be surprised, in all the meets of ABSI, the participation is 100 plus, in small meetings, and in big meetings 500 plus. So that is the magnitude of, you can call it manifestation of surgery that we are finding in ABSI. ABSI is a leader in context of breast diseases all over India. And we have been trying to formulate the academic programs, details of it, so that the academic part spreads out in a proper way and in an organized way all over India. The basic intention is to have a common platform, especially in the B and C class cities, because initially what used to be the fashion is really Mumbai or Calcutta used to host the most of the programs, and B class and C class cities used to be left out, and the knowledge used to be practically gained at the level of the metros, not at the suburbans or the B class and C class cities. Now you'll find a radical change. Most of the B class cities and C class even are striving hard to bring the breast disease or the knowledge of breast to the national level as well. So today, since morning, we have been striving hard to organize the surgical oncology workshop, and it was a big success. We thought at 9:30 there won't be anybody to attend the conference, and we'll be surprised that the hall was full. There were more than 100 participants already in the hall by 9:30. That is a big, I will call it achievement to the ABSI team as well. And definitely the organizing team. The best part is that we have formed a Bihar Breast Group to support the ABSI in this cause, and I've requested all of them to become a member of ABSI, because here we are planning to percolate deep into the roots, so that every surgeon who is trying to or aspiring to become a breast surgeon should understand what oncoplasty is. As in the morning we were talking about, like, surgeons were restricted to biopsy, as said by Dr. Advani in the almost 15 or 20 years back, that surgeons will be reduced to doing biopsy. But after 15 to 20 years, we find that we are more robust in our approach, and we are doing more surgeries in a better way and more radical approach rather than a conservative or a side look attitude as such. So with these words, I welcome you all delegates. We have faculties from India, all over India, abroad. We have from Chennai, Bangalore, Mumbai. We have from Pune. We have from Calcutta, Delhi, all over India, across India, we have the faculties. And there are many participants as well from all over India, all the cities, you'll name it. And we have Dr. Rishikesh Parmeshwar, who has been kind enough to give us lend us support. In fact, a real son of a soil is Dr. Rishi, who has always been at support and has never said no to us whenever we have organized any program. So thank you, Dr. Rishi, for coming from that far off, taking so much pain. The plane got cancelled twice or thrice, but still he made it, and thank you for that, all the efforts. So with these words, I leave the forum to our Dr. Rahul to continue with the program further on. And thank you once and again, everybody, for joining us in this ABSI SKILLCON. I wish you all the best for the next day, which is coming tomorrow. Thank you.
Thank you, sir, for setting the tone for this academic gathering. May I now invite Dr. Akash Singh, the Organizing Secretary, to present the Secretary's report.
The Association of Breast Surgery of India conference is a premier academic platform dedicated to advancing the science and practice of breast surgery in India. It brings together leading surgical oncologists, clinicians, researchers, and allied healthcare professionals from across the country and beyond, fostering a collaborative environment for knowledge exchange and growth. Under the leadership of ABSI, ABSI SKILLCON 2026 is now being arranged at Patna. It gives me immense pleasure to present a brief summary of the proceedings of ABSI SKILLCON 2026 Patna. The conference commenced with an engaging and highly informative morning session featuring a live breast surgery workshop. This session provided participants with a valuable opportunity to observe real-time surgical techniques, enhancing their practical understanding and encouraging interactive discussions with expert faculties. Following the workshop, the conference is now transitioned into a series of scientific sessions. These sessions include insightful lectures, case discussion, and evidence-based updates delivered by distinguished speakers in the field of breast surgery. The organizing committee expresses its sincere appreciation to all participating doctors for their enthusiastic involvement in the ongoing breast cancer workshop and scientific sessions. We extend our special thanks to the faculty and delegates from various medical colleges across Bihar for their wholehearted participation and support, which has greatly contributed to the success of this event. A noteworthy highlight has been the overwhelming participation of postgraduate residents in the poster competition. Their innovative research work, scientific curiosity, and commitment to academic excellence are truly commendable and reflect a promising future for breast cancer care. Thank you.
Thank you, Dr. Akash, for the Secretary's report. May I now invite Dr. P.K. Jha to kindly introduce Dr. Navneet Kaur, President-elect ABSI. She will be presiding over the inaugural session.
Dr. Professor Navneet Kaur, MS FRCS, PhD, and is a distinguished academic surgeon and a leading expert in the breast surgery, currently working as a director, surgeon, breast oncology, Max Super Speciality Hospital, Noida. She has more than 100 publications and various guest lectures, and now she elected President of the Association of the Breast Surgeon of India. She is pioneer breast oncoplastic surgeon of the India, and now we invite you, ma'am, for the lecture. Thank you.
Good evening, everyone. It's my proud privilege and honor to be here as President-elect of Association of Breast Surgeons of India, and in fact the first woman President of the association in its existence of 15 years. So ABSI started as a small movement about 15 years back in a boat club meeting in Hyderabad in 2011 with some 25 members gathering there and deciding that there is a need to start breast as a subspecialty under the banner of ASI. And post that, I think we held our first conference at Hyderabad at 2015 12. So it's been about 15 years. What started as a movement of some 25 like-minded people has now really expanded into a big organization, into a big association with a very strong presence. And I would like to thank Dr. Vijay and his team for hosting such an important event. In a Tier 2 city, so-called Tier 2 city. I think Patna also looked very impressive today when we landed at the airport, very developed. So purpose of ABSI has been to be the voice of breast surgery in India and bring the standards of care to the doorstep, if I can put it that way, to every Indian patient. And in this journey, we needed support of people to join and host such meetings. So such meetings hold immense importance because we have seen that the field is evolving so rapidly. Those changes which did not happen in 100 years are happening now in 1 or 2 decades. Though there is a constant threat to the existence of a breast surgeon by the advances in precision oncology, and if I'm truly inspired by the speech of Dr. Lemay and the vision that she has of precision oncology, melting away diseases just by finding the right kind of drug for a patient's problem. But till we achieve that vision and a goal, there is a long journey to cover. Surgery is going to play an important role in the entire journey of the growth that is going to be there in breast management of breast cancer. Intention is always to work for the interest of the patient and give what is the most appropriate. So whether we are escalating surgery or we are de-escalating, it is all a matter of definitions. The ultimate goal is that patients should have a better quality, good quality of life, practically not remembering that at all she had a cancer in her body at any point of time, and body should be as normal, as pleasant as it was before the diagnosis for breast cancer. So in this journey of constant evolution, we have new technologies, and such platforms provide us the opportunity to share the skills, share tips, get updated about what's recent in the field, and that is how we are probably going to carry on the movement and ensure that the best of the breast cancer care reaches in all parts of India, be it Tier 2 or Tier 3 cities. And at the same time, just to ensure that we do the equitable access to the care is available. So what is available as a most expensive treatment in the best of centers should also reach to the periphery, to the poorest of poor, with the developments which bring down the cost and find solutions to the local realities of economics, the cultural perspective and everything. So with that, I think I don't have to say much. We already are quite late for the day. And I hope you will, in the next 2 days, learn even more and upgrade about the latest in the field. And thank you once again, Dr. Vijay, for bringing so many people together, for bringing such exciting speakers here and giving us the new insights and making the movement grow as we pass. Thank you so much.
Thank you, ma'am, for your inspiring words and valuable insights. It is so befitting that we have a woman as the president of the ABSI, breast cancer being largely a woman's disease. So may I request Dr. Manish Kumar, HOD Surgical Oncology, IGIMS, to deliver the vote of thanks.
Good evening, everyone. And today is the session for the ABSI, and respected President-elect of the ABSI, distinguished faculties and dear colleagues. On behalf of the organizing team, I extend our sincere thanks to our patron, President-elect, for presiding over the inaugural ceremony and for inspiring speech. I would like to thank our esteemed faculty members who has taken their time out for this academic feast and given their full cooperation. I would like to thank our resident and other faculty members for their time for this conference. My heartiest thanks to all the delegates and the participants whose enthusiasm makes academic meetings like this fully meaningful. Finally, I acknowledge the efforts of the organizing team with a special mention to the Savera Cancer Memorial Hospital and members of the Bihar Breast Group and industry partners with who have worked relentlessly to make this CME possible. I would like to thank the media for giving the CME their coverage. Thank you all, and we look forward to a stimulating and enriching academic program ahead. Thank you.
With this, the inauguration ceremony comes to a close. I would request the office bearers to please take their seats in the audience, and we will proceed to the next scientific session. Thank you.
Moving to the next session for keynote address on the topic of one size doesn't fit all, I may invite to the dais our chairpersons. First and foremost, Dr. P.K. Jha, IGIMS Patna. Kindly join on dais. Followed by Dr. Manish Mandal, IGIMS Patna. Dr. Paulami Mukherjee, Assam. Dr. R.K. Saxena, SCMH, Patna. Dr. Nilmal Kumar Sinha, NSMCH, Patna. Ladies and gentlemen, put your hands together and please welcome, huge round of applause. I request Dr. Paulami Mukherjee ma'am kindly introduce our next speaker to conduct this session.
Thank you very much. It is my honor to introduce our next speaker, Dr. Amar Deshpande. He's a consultant surgical oncologist, the breast division, and associate professor of surgical oncology. He's a very inspiring clinician with his patient-specific approaches, especially his innovative approaches and successful implementation of daycare breast cancer surgery in Tata Memorial Hospital. He's a teacher par excellence, and as an academician, he has several accolades to his name. Sir, we welcome you to the dais.
Zordar taaliyon se swagat kijiye for our next speaker. Over to you, sir.
Good evening, everybody. That was a very kind introduction, Dr. Paulami. Thank you for that. I would like to thank Dr. VP Singh and the team for inviting me to do this talk, which is a kind of a challenge. However, I agree with Dr. VP Singh that well begun is half done. And the previous speakers have done that half job for me already. So I'm not going to give you much data or anything. I'm not going to keep you from your dinner for too long. I'm just going to put my case forward that one size does not fit all. So I've got this case. This is a lady with a B-cup breast. She has got a 5 centimeters grade 2 invasive ductal carcinoma in the upper outer quadrant. Node negative clinically and on radiology. ER positive, PR positive, HER2 negative. What would we do? Anyone? Yeah, some people would say NSCT to downsize it. Okay, NSCT is done. It has reduced from 5 centimeters to 4 centimeters. We would give options of mastectomy and some kind of volume replacement, right? So the patient chooses volume replacement, we do that. What if it is triple negative? We'll definitely consider NSCT. So the same patient, the biology is different, we have decided for a different management. If the same cancer was in this breast, perhaps we would again think of NSCT, etc. But we could do a therapeutic mammoplasty as well, right? So if I was a lawyer and I was in front of a judge, I would say, I rest my case and walk off from here. but I'm not, fortunately, a lawyer, and therefore I have to continue here. If it was triple negative, we can again do the same NACT, but we can still do a upfront surgery if we are forced to do it. So we know that breast cancer is the most common cancer, and when the treatment of breast cancer started, it was radical mastectomy, and we have progressed from there to less is more when it is oncologically safe. So tumor biology is the king. We know that. We have to tailor our management to the tumor biology. And ER/PR positive cancers, we already saw that in the last two slides. They are endocrine responsive, but they may not respond so well to the chemotherapy. So we might just do upfront surgery, but if they are triple negative or HER2 positive, we might consider NACT. So again, we are not using same approach for different biologies. So we know that in NSABP B06, they have proved that lumpectomy and radiotherapy is as good as mastectomy, or perhaps some of the recent papers show that it is better than mastectomy from a long-term overall survival point of view. So again, there is a shift of the paradigm from more radical surgery to less radical surgery, maintaining the oncological safety. Axillary de-escalation, Chanakya has already spoken about it, so I don't have to say much here, but what we are seeing is more and more de-escalation of the axillary treatment. However, are we really de-escalating the axillary treatment? Some patients we are advising radiotherapy. So on one hand, we are de-escalating the surgery, but on the other hand, we are escalating with some other treatment. So is it real de-escalation? In any case, we are using different modalities, different options for different patients with different biologies. AMAROS trial, we all know axillary radiotherapy and axillary lymph node dissection compared, there is equivalent regional control. So again, have we de-escalated? I don't know. Oncoplastic surgery, we are using various types of techniques, and we have seen since morning that we have used quite a few techniques. We have shown quite a few techniques, and the patients were different. However, biologies were probably the same, and it was tailored to each patient's need. Each operation is tailored, and it has to be tailored to each patient's need as long as it is oncologically safe. I'm saying this again and again, and I'll keep on repeating it at the risk of boring you all, but that's what we need to do. Neoadjuvant chemotherapy we are using to downstage the tumors, especially the more aggressive ones, and we know that triple negative tumors or HER2 positive tumors are more likely to respond very well to the neoadjuvant chemotherapy. We can even see a complete clinical response and complete pathological response as well. It also enables us to do targeted axillary surgery. The standard treatment at the moment for a positive axilla after NACT is axillary lymph node dissection, but we are exploring the other options as well. Targeted axillary dissection, etc., etc. So we have got other options, and soon that will be tailored to each patient's need as well. Reconstruction. Depending upon what the patients want and what the patients need, we can offer various types of reconstructions, and implant-based versus autologous, it comes to patient's preference as well as what they really can have. So consider implant-based reconstruction. A relative contraindication is need for radiotherapy. It used to be an absolute contraindication, but in such cases, we'll choose autologous reconstruction more than implant-based reconstructions. So once again, we are giving the patients what they need and not what we want them to have or what they want. Genetic and risk-reducing surgery. We know that the patient, suppose a patient has got a cancer that can be treated with BCS, we have to offer risk-reducing surgery if they are BRCA positive or genetic positive. So contralateral mastectomy, whether it is needed or not, we have to offer that because genetics is demanding that. And also triple negative cancers, we can think of PARP inhibitors, etc. So again, we are tailoring the treatment to the need for of that patient. Elderly and frail patients, we try to do one surgery and try to keep it to as simple as possible. But at the same time, younger patients, we would do something else. So once again, we are now thinking of what the needs of those individual patients are. And young patients, we know they have aggressive tumor biology. Fertility preservation is something that we must consider in these patients. And also, long-term cosmetic planning has to be done because they have got so many years in front of them to look forward to. And once again, radiation may be a relative contraindication. So we might think of autologous reconstructions. We also might think of the financial implications there. Implants may need changing after so many years. So we would think of that as well while planning the reconstruction. Patient choice is important. However, if the patient wants something which they are not suitable for, oncological safety takes priority over everything, and we have to explain to the patients that that particular option is not available for them. So once again, I'll say this, oncological safety is paramount. We will give the patients what they need and not what they want or what you would like them to have. Complications, we have to think about the margin positivity rates. Margin positivity, we can revise the margins, but if they have very small breast with major loss of tissue, major loss of volume, we may have to consider mastectomy. So again, we are thinking of what that particular patient needs. Lymphedema, it's more in high BMI, diabetics, etc. So we would think of lymphovascular anastomosis in those patients, not in everyone. High tumor, high axillary burden, again, we'll think of lymphovascular anastomosis. So that's why we have got guidelines. We have got guidelines because we have got multiple options. And the guidelines teach us to, or guide us to select the right kind of management for a right kind of patient. So the take-home message is, give the patients what they need and not what they want or what you want them to have. So therefore, one size does not fit all. These are the few references that I have used, and I'll finish early, won't keep you too long from your dinner. Thank you.
So very good talk. And any questions from audience?
Thank you all. Oh, there is a question there.
Other tests, genomic tests like other receptor tests that you routinely now practice in your institutions?
Well, in PMH we get Chi67 as well, but we are not basing our management based on that. And also genetic testing is done for selected patients, not for also triple negative young patients, HER2 positive patients when they are under the age of 50, etc. So we don't do anything specific from that point of view. Is that what you wanted to ask?
No, sir. We are in 2026, from right now, when you see in future that for every individual patients, you'll be doing all kind of genetic tests and individualize the treatment based upon those tests?
Yeah.
When you see that happening?
When the genetic testing becomes available everywhere, and it's still quite expensive to have genetic testing. So I don't think it will be available everywhere. It's also something that needs a lot of work done. So I think in Tata we have got a lab, but there are some private labs in Mumbai, but it's not available in all the hospitals in Mumbai either.
The idea for asking these questions are, there are few tumors, even if you don't do anything, they will grow small, they won't metastasize, and patients are not going to die. We have seen that in breast cancer. There are few reports that are published that the cancer remain localized disease. So we are sometimes giving over treatment, sometimes we are giving under treatment. So things what we are speaking in the past, in 2000, if you say that other than MRM, nothing, breast conservative has a high recurrence rate, now we say we go for breast recurrence surgery. So the idea of asking this question is that when you see in future happening individualist based treatment based upon genomics?
Now, based upon genomics, I don't think we can, but there are other tests like to decide chemotherapy, benefits of chemotherapy, like Oncotype DX test. So those kind of tests we are basing our decisions on, especially in the Western world. I don't think Oncotype DX is validated for Indian population yet, but that is being used as well. However, I don't think we can still say that we can use these tests to cater to Indian population.
So thank you. That was a very excellent talk. Just an extension to what was asked previously is that in the hereditary breast cancers, would you do anything else apart from your BCS and MRM?
Anything less?
Anything else?
Anything else?
Yes.
So I always talk to my patients when there is a definite BRCA mutation or any other mutation that is pathogenic, and if it is variant of unknown significance, then I would just treat them as usual. However, if it's a pathogenic variant, then I would discuss the risk reducing surgery with them.
Yeah.
I would also discuss the risk reducing ovarian surgery with them.
Yeah. Sure, thank you so much.
Okay. Thank you very much.
It's time for the photo session. I request our speaker, Dr. Amar sir, and our chairpersons kindly come forward for the photo session. Just quickly get into the next session, and that is panel discussion, the most anticipated segments on the topic of benign breast disease. First and foremost, I may invite on dais. Ladies and gentlemen, please put your hands together and please welcome Dr. Usha Dadwani and Dr. Nibha Mohan, our chairperson. Usha Dadwania and Dr. Nibha Mohan. जोरदार तालियों से स्वागत कीजिए for our chairpersons. Ladies and gentlemen, please welcome our panelists for this session. Dr. Manjula Rao, Apollo, Chennai, followed by Dr. Shalaka Joshi, Dr. Dipendra Kumar Sarkar, Dr. Shalaka Joshi ma'am, Dr. Dipendra Kumar Sarkar, IPGMAR Kolkata, Dr. Anand Mishra, KGMU Lucknow, Dr. Madhukar Dayal, Patna, Dr. Pranav Verma, SCMH Patna, Dr. Namrata Mansaria, Ranchi. To lead this high-stakes conversation, please welcome our moderator, Dr. Arunima Verma. Ladies and gentlemen, put your hands together. Dr. Rachna, MCH, kindly join to the dais. I request our chairperson, Dr. Nibha, ma'am, kindly introduce our moderator.
Good evening, everyone. At the outset, I must thank Dr. VP Singh and his team for giving us this opportunity to have this wonderful session of panel discussion. May I introduce Dr. Arunima Verma, who's going to moderate this interesting session of benign diseases of breast. Dr. Arunima Verma is MS, FRCS, FSCS, and many more. And she's working as Chief Medical Superintendent and Head of the Department Surgery, Tata Motor Hospital, Jamshedpur. To her credit, there are more than 20 publications and more than 80 presentations. And she's also working as Editor-in-Chief of Jharkhand Surgical Chronicles and International Surgical Ambassador for the Royal College of Surgeons of Edinburgh. She is also Executive Committee member of IGIMS East Zone and tutor of ESSQ Long Distance Learning Program for medical students, chairperson of Jeevan Jyoti School Nursing Jamshedpur as well. And she has been organizing secretary of many conferences. And she's also involved actively in NABH activities of Hospital Coordinator for Clinical Audit Program at TMH Jamshedpur. And she is at present honorary tutor in surgery at MGM Medical College Jamshedpur. So such a wonderful CV Dr. Varinama has. And we request you to start the session. Before that, my chairperson, Dr. Usha Didwania, want to introduce the topic.
Good evening, and thank you, organizer, for giving us this opportunity and organizing such a wonderful conference today. It is a very important topic. Globally, 30% to 60% women are affected with some or other breast condition, and gynecologists are the first person to come in contact with these patients. And when we see a lump, we must suspect it with we should see it with suspicion unless otherwise proved it to be benign. And the one thing, there is no replacement of thorough history and thorough clinical examination. And we have got many modalities, triple assessment or risk assessment models at hand. Clinically, we can use it to diagnose a case to be benign or malignant. And the most important aspect, not to be this should not be overdiagnosed, should not overdiagnose or overtreatment, and at the same time we should not miss a case of malignancy. And we have got learned panelists and moderator to throw light on this topic, and we will be benefited with this. Thank you.
Thank you so much, chairpersons, for the kind introduction and also for introducing the topic so well. And I can now first thank Dr. VP Singh for organizing such a wonderful conference and giving me this opportunity. At 8:30 p.m., when you see a hall packed, then you understand the impact that you have. And I can also complain that a disease which takes 80% of the burden, you have given less than 5% of time in this conference. So bringing you back from cancer to benign breast diseases, we have a panel of learned people, Dr. Manjula Rao, Dr. Shalakha Joshi left because she had a flight, Dr. Diptendra Kumar Sarkar, one of my mentors, Dr. Anand Mishra, Dr. Madhukar Dayal, Dr. Rachna, and Dr. Namrata Mahansaria. And to start with, I think ma'am already said, benign breast diseases constitute 80 to 90% referrals for breast clinic, and they are 10 times more common than the breast cancer. However, the problem is that due to lack of RCTs, there is insufficient evidence to confirm or refute many management strategies in benign breast diseases. And because of this, what happens is that these women, who are around 30% of women, suffer from some kind of benign breast diseases requiring treatment, and they are either overdiagnosed or underdiagnosed, and they have unnecessary surgical intervention. irrespective of the type of lesion, which is not recommended. And what happens with benign breast disease is that it might not be a killing disease, but it has a lot of psychological disturbance because the woman lives in fear of cancer. So with this, I'll just try and classify the frequently encountered benign breast diseases. So we can classify them into development abnormalities, inflammatory lesions, fibrocystic changes, stromal lesions, and neoplasms. The fibroadenomas being the most common benign breast disease, and then we come across with a lot of inflammatory things like mastitis, which could be acute, chronic, or granulomatous mastitis. And there can also be mammary duct ectasia, and we are usually challenged by all these. So to start with, this is a first case where a 34-year female, para 1, L1, recent delivery 3 months back with lactation, presented with lump, and she had fever, and she was treated with breast milk suppression therapy. The lump persisted and pain increased with fever since 1 week, and there was no comorbidity, her vitals were stable. On local examination, there was an ill-defined approximately 8 by 7 centimeter lump in right breast with local rise of temperature and tenderness. This was the ultrasound which showed a hypoechoic collection at the left subareolar region with a volume of almost 152, and liquefaction was noted. There was some thickened tissue in the right mammary region, and there were few small nodules around 1 centimeter in the right breast. With this, there was a diagnosis of lactational breast abscess, and what we agree on about lactational breast abscess is that it is an inflammatory condition of the breast associated with lactation, also known as lactational or puerperial mastitis, and 2 to 33% of breastfeeding women might develop lactational mastitis. And galactocele is another condition which occurs during lactation, which is a retention cyst, and when it gets infected, it is also a breast abscess. So with this background, let's get some consensus. Should breast milk be suppressed to treat lactational mastitis? Can Dr. Manjula take this question?
So that was the first thing that struck me when you put up your slide. Typically, we don't need to suppress a woman lactating in order to treat the mastitis.
Yeah, and besides ultrasound, is there any other investigation? I think a radiologist can take that question.
Ultrasound is quite good enough. It will give you every picture, whether it has converted into an abscess or not, whether it's just a galactocele, which is another thing that you frequently get in these patients. And it's more of a you need to exclude other things, because clinically also see fits into the same way. I don't think you need any extra investigation.
Anand sir, should antibiotics be prescribed to all or a selected group? And if yes, then which antibiotics and for how long should it be given?
So yes, I agree, antibiotics are needed because it's an inflammatory condition. Most of the time the bacteria, they travel through the duct, from nipple, and then the inflammation, and then mastitis component, and then liquefaction, and then obviously an abscess. So initially you can have a broad spectrum antibiotics, cloxacillin, gram-positive antibiotics. Then when you aspirate it, send that sample for the culture sensitivity, and then another decision can be based on that culture sensitivity. So obviously antibiotics is needed.
Diptendra sir, if the breast abscess is confirmed, what would you do, aspiration or an incision and drainage?
Of course, if it's a lactating mother, the question of incision and drainage does not come. Generally in breast abscess, the principle is aspiration only. However, the caveat is, quite often we find that primary treating physicians would actually prolong the treatment without doing an ultrasound with antibiotics for quite a long time. So in these patients, when they come quite late, you have multiloculated, almost indurated. In those cases, the dilemma comes up. General principle wise, we should not be putting our knife in any breast abscess, let alone lactating mothers.
Yeah, and Namrata, should breastfeeding be continued?
I prefer continuing with the breastfeeding, ma'am. That's one thing that I think should continue for at least 6 months. This is only a 3-month-old child, so that is very particular.
So the only concept was that breastfeeding with an infection, at times it has been reported to have lung infection for the child. So keeping that in mind, but however, I do agree with you that breastfeeding should be continued, and we'll have a consensus on that. And is there any role of probiotics or any other agents? Anybody can take up this question?
with antibiotics, I usually give probiotics. I don't know how much, but especially with amoxiclav, it's my preferred thing to do. Otherwise, the antibiotics are stopped midway. So.
Right, and are there methods to prevent the lactational mastitis?
Yes, of course. Now, you know, these days, we should be counseling a mother about the proper latching technique during the final trimester of pregnancy. And at the same time, the lady's nipple should be observed. Quite often, some of them will have a flat nipple or a cracked nipple, which actually is deterrent to breastfeeding. So a good obstetrician examination in the terminal part of pregnancy is extremely important, and teaching them proper latching reduces the chance of mastitis.
Yeah, so I think we have got a lot of consensus, and I'll just point out what literature says. So as Dr. Manjula rightly said, that milk suppression agents are usually not given, and they can be reserved for recurrent cases. And we also need to remember that there is rebound lactation after 1 to 2 weeks if you have given a pharmacological suppression. Also, when you're choosing your antibiotic, the milk leukocyte count and the bacteria can be identified, and accordingly you can give. However, rightly said by Anand sir that cephalexin, dicloxacillin, all that, these are the ones because staph is the most often offendant. And as far as treatment is concerned, the WHO supports ultrasound guided aspiration for up to 3 centimeter, and if it is more than that, a catheter drainage can be done. And as far as IND is concerned, you need to only do when you see skin changes in the breast, that you know they have got signs of necrosis happening, and then you do it. And when we come to drainage of breast abscess, breastfeeding should actually be continued. That is what WHO has done. And probiotics, they have shown to reduce the risk of mastitis more than placebo. However, we need more trials. And what breast care that Narendra sir was saying, and there's a study actually that has been done by Chinese acupoint massage that has also found to have less lactational breast abscess. And nisin, it is a naturally occurring antimicrobial peptide. It has shown some potential in healing mastitis. However, it is more used in the veterinary setup, and it is not yet FDA approved, but still some physicians have used it. And in this particular case, yes, we did give antibiotics, and we did 4 sessions of aspiration. However, that did not subside. So what you see in the video is catheter insertion under ultrasound guidance. And then this we kept for 5 days, and on a daily basis we were doing an ultrasound to look at the breast cavity, and in the right side you can see the catheter in situ, and after 5 days the catheter was taken out. And this actually works. I do this quite often in my practice when I come across with large breast abscesses, and IND can actually be avoided. So with this, we move ahead, and just looking at some studies, when we talk about needle aspiration, it definitely has better advantage in terms of healing time and avoidance of breast fistula. Coming to the use of antibiotics for mastitis, there is insufficient evidence to confirm or refute the effectiveness of antibiotic therapy, so we need more studies. And I just mentioned about this Chinese massage in the treatment of acute mastitis. It is a RCT that has been registered, so we need to look for the results. So now coming to another case, and this is a long case history over 4 years of a 30-year lady. In May 2020, she presented with pain left breast, and she had a history of abortion 10 days back. And radiology showed a Birad's 3 lesion. FNAC showed acute suppurative inflammation, and we treated her with antibiotic and breast support. However, again in July, she came back with multiple sinuses discharging from that site of breast. Again, mammogram and HRUSG was done. Again, it showed Birad's 3 lesion. So we did an excision of that lump, and that came out to be breast abscess, acute and chronic mastitis with multiple micro abscesses. So after that, again in December, she came back from discharge from operated site. Ultrasound again was normal, and we did a discharge, was sent for culture and sensitivity. There was no growth. Again, we did give her antibiotics empirically. Then she recovered on that, and she was in continuous follow-up. In April 24, again she came with pain and swelling on the right side of breast this time for 3 months. And this time when ultrasound was done, again it was breast abscess, but this time we went ahead with an MRI. An MRI suggested a Birad's 3/4A lesion. So we went ahead with a breast lump excision, and this time it came out to be cystic neutrophilic granulomatous mastitis.
Now, I'll just set a background for idiopathic granulomatous mastitis, that it is a rare chronic condition characterized by relapsing sterile draining breast abscesses. Exact etiology is unknown, however, proposed etiology is autoimmune reaction, hormonal factors, local inflammation, and some species like Corynebacterium are also said to cause it. Risk factors include OCP, breast trauma, smoking, and diabetes, and it is actually a disease of exclusion. And gold standard treatment modality is debatable with no clear consensus. So, Dr. Mayank, you can answer that. What is the role of radiology in IGM and what should be the best imaging modality?
Sorry, Madhukar.
Oh, sorry.
Yeah. See, we don't get a diagnosis like IGM. What we get is a microabscesses. In our practice, what we give it is as like to rule out tuberculosis, first of all. We frequently do a biopsy for such cases. We send it for culture, gene experts and other things that you know. But I think you can do, we can do a big core biopsy, like vacuum is very indicated in
I've
such
just
cases.
put on the ultrasound mammography, however, I could not find the MRI. She had a MRI done somewhere outside, so I couldn't get those.
So this is a complex type of a lesion, hypoechoic obviously, but all the category that Dr. Sanjay must have shown you, it is having a background enhancement, so it looks more of a benign type of a lesion, not a malignant one. So, and the mammography also, there is some focal asymmetry and not a high density mass which can be seen. Obviously this is a Barrett's 3 lesion, and the way you do a biopsy is more important, because to call it an idiopathic, you must rule out all other things.
Correct. So I think he already described this, and since it was a 3/4 lesion, this is a mammogram of another lady with her IGM, and here, as he said, that we do not diagnose granulomatous mastitis. However, here in the mammography, it was mentioned query granulomatous mastitis, query neoplastic etiology.
I think
because
this
it
is
at times
over-interpretation of the images. Again, as ma'am said, we should not go so far ahead that we look back to one case, okay, I have seen one mastitis granulomatous, and the next case I am labeling it the same.
But we do have confusion as far as granulomatous mastitis is
cannot label
concerned
it
with
on
neoplastic etiologies. We do have that.
Yeah.
It is.
But you cannot give it a
does
diagnosis
mimic.
on mammogram.
No, it's a query, but obviously you do have signs of inflammation when you do a...
See, if I interpret this mammogram as a radiologist, I'll do an ultrasound first, because this is Barrett's category 0 for me on just a mammogram. I will not level any Barrett's on this. Because this is a dense breast, there is focal asymmetry, and this will not fit into any of the radiological categories until unless you combine it with a ultrasound. So just a take-home message here. Many a times we the radiologist only, we give a diagnosis on mammogram itself, but this is 0. This is Barrett 0. Yeah, I know. I have not read the entire report. So you have to correlate with USG, and then you have to come to a final diagnosis.
I think most of the centers who are doing mammogram do correlate it with an ultrasound and then only give a report. So, yeah.
I have a slightly conflicting opinion. I would actually appreciate this radiologist because he or she has looked and suggested 2 different possibilities. One is on the benign spectrum and one is malignant. So I really appreciate this individual, because the mammo is very confusing. It's extremely dense. So obviously whatever they've reported is on ultrasound correlation and possibly correlation with the clinical symptoms as well.
I think Diptendra sir wants to add something.
Yes.
Yeah.
Yes. Number one, in India, if you look at the age, the mean age when IGM presents is usually in the early 30s, within 5 years of initiation of lactation. So generally, that's not the age where somebody would do a mammogram. So usually between the first part of the 30s. So I personally, in my clinical practice, is happy with an ultrasound only.
Also, I would like to add, just see, I mean, clinically you make a diagnosis of a granulomatous mastitis. Now you are not confirmed whether it is idiopathic or tubercular or any other variety. That's one question you need to answer by investigation. The purpose of investigation is other purpose is that you want to see whether there is any fluid collection or not. You want to aspirate it, send it, you want to rule out the different type of granulomatous mastitis. By mammogram, you want to see the extent of the disease involvement. You are not concerned for the Barrett's now. If there are any other lesion lying behind that, then you are concerned and you want to characterize that lesion. So that's the purpose of the imaging.
Yeah, agreed, sir. Purpose of imaging is very clear that in all breast lesions we do a triple assessment. That is very clear. But what I was discussing was that does mammogram show anything? And this was actually, this patient had come with this mammogram. However, it did give us an insight, and we do, as surgeons, we know that granulomatous mastitis can mimic breast cancer. So that's a message that I would like to give. And I think he has already said imaging as far as granulomatous mastitis can be ambiguous. Mammography, ill-defined density with speculated margin can come. Ultrasound, abscess formation with tubular extension and hypoechoic mass with or without enlarged lymph nodes can be seen. And MRI, I'm sorry, it just became larger. Okay, sorry. So MRI, one or more masses with ring or nodular enhancement may be seen. It's stuck. I'm sorry. It's not moving. Okay. So I come to Dr. Rachna, that what is the role of FNAC when we talk about granulomatous mastitis? And what would you suggest, true cut biopsy, core-needle biopsy, or excisional biopsy?
Yes, definitely there is role of FNAC, because many of the times when we aspirate and make smear and we can find granuloma, and the background of the granuloma, it also defines the type of etiology it could be. If it is associated with caseation necrosis, then it hints towards the tubercular etiology. But many causes can be, but it guides, it hints the cause. And true cut biopsy, I think in this case, FNAC smears can guide us, and culture sensitivity can be done on FNAC smears. So biopsy, if FNAC smears are inconclusive, then we can think of true cut biopsy.
Do we agree as surgeons? Yes.
Any lump coming to me first after my radiology would always be a true cut biopsy. So, and specifically for a granulomatous mastitis, I think it's very important. One, identification of the granulomas, of course, in the biopsy specimen. Also, I am glad, I am not sure how many pathologists actually identify not just the granulomas, even the TB microbes, right? TB microbes on the, but they do mention, my pathologist always mentions that there's not visible. So the idea to go in for CBNAT, yes or no, is also, it also is helpful from the biopsy.
I think that is what Anand sir was mentioning, and then I think he can take this question, the role of AFB staining, BACTAC, CBNAT, especially in countries where tuberculosis is prevalent, and definitely as far as India is concerned, it is prevalent. So sir, do you routinely do that?
So you only said that it is a diagnosis of exclusion.
Correct.
So obviously you do an ultrasound, it's a clinical diagnosis, then you do an ultrasound, whatever fluid you have, if you can aspirate, send it for the AFB, for the CBNAT, take a core biopsy, that will give you a complete diagnosis that it is. Now you know an extent of the disease. Excisional biopsy you ask, excisional biopsy comes at the last because it's a medical treatment initially. If you come to the treatment, we give the injection treatment of the steroid injection treatment, and if after 3-4 cycle there is a residual treatment and it is stable, it's not going, then only excisional treatment comes, surgical treatment comes into the picture.
So these patients at times present with those sterile pus, so AFB I think we all do, as far as I am concerned I do that, so I think we may agree on that. And role of biomarkers, Dr. Rachna? Okay, I think anybody wants to take this question on role of biomarkers? Diptendra sir?
Well, no role of biomarkers. Now, if you look at this, this is the signature of an IGM. For any trainee sitting here, do not, for God's sake, stamp it empirically as tuberculosis and start ATD. It's like blame it on the Rio. Whatever happens, it's tuberculosis in India. Now, if you have a non-caseating granuloma, that's an IGM. And if you have a caseation, that's a tuberculosis. So that separates out right at the beginning whether you are dealing with an autoimmune disorder or an infective disorder. So that should be the signature of IGM.
But would you do some other tests for other non-caseating granulomatous diseases?
Well, you should be clinically correlating. I have had patients with vaginous granulomatosis, with sarcoidosis, with some collagen vascular diseases. But you know, these patients typically do not present with these. Quite often patients of IGM will present with reactive arthritis. That's very common, particularly in the ankles, but that comes after the IGM has started. Whereas if you look at collagen vascular disease, the patients will suffer from some arthritis and later on they might develop IGM. So that way you can differentiate whether it's a reactive arthropathy or it's a primarily a collagen vascular disease presenting with an IGM.
I think a very important point made, and I think we should take it as a take-home message, and this is what the signature granulomas of IGM look like. It's the low power field and the high power field, where you see giant cells, lymphocytes and epithelioids. And this particular case, this is the biopsy of the particular case because it had mentioned neutrophilic, cystic neutrophilic granulomatous mastitis. And this is the granuloma in the first slide. In the second one, you can see the cystic space surrounded by neutrophils and histiocytes. So this is a particular variety of IgM. So that is just showing this particular case. So FNAC has poor diagnostic rate and useful only when performed along with drainage of the fluid collection. Core needle biopsy is the modality of choice, we all agree. Excisional biopsy, already pointed out, adds no advantage and leads to more morbidity. In developing country, we would definitely go for a tuberculosis test. And there are multiple biomarkers which are coming up, but we need more research to see what is their role as far as diagnosis and treatment is concerned. Yeah.
So granulomatous mastitis many a times is one of the presentations of an autoimmune systemic disease. So these patients should be carefully evaluated for any history, I think as Dr. Sarkar already pointed out, arthritis, also skin lesions. Yeah. And if any of these are present in the history itself, then some kind of anti-nuclear testing for Rh factor, anti-nuclear DNA, these all tests can be added because I would not say very frequently, but quite often, and then we are able to pick up the disease early and identify before it causes more mild manifestations.
Yeah, definitely I agree with you. It has to be a holistic management, and again we re-emphasize that it's a disease of exclusion, so you need to look at all those aspects. So coming to treatment, Diptendra sir, what should be the first line of treatment?
Well, I have developed my own algorithm depending on the publication that I had. Now it's very clear now, if you have a patient presenting with a lump only, and you have proven it, there is no sign of inflammation, it's a small unifocal lump without skin involvement, don't do anything, just observe. If you find it's a growing lump and or you find sinuses and it's multicentric, put the patient on steroids or injection therapy. If you find a solitary sinus which is connecting to a duct, go for a total duct excision plus en-bloc removal of the lesion. Generally the policy should be conservative, and definitely there is a role of no treatment, but that is only for very early small lesions incidentally detected. Those cases you can just safely observe, most of them might not manifest.
Correct. Dr. Manjula, role of antibiotics, and if yes, how would you choose?
So the protocol that I usually follow, I agree with Dr. Sarkar when he said that, if there are no signs of inflammation, you don't start antibiotics. I haven't come across that scenario very often. So more often than not, they come with discharging sinuses and redness and features mimicking malignancy. So what I always do is, once I know that it's a granulomatous mastitis, we aspirate it and under antibiotic cover. If you don't aspirate it, the antibiotics don't work. And literature has shown us that Corynebacterium is a very common pathogen that is found. So usually they respond to doxycycline. So more often than not, all my patients, I start them on doxycycline for 21 days. I inform them about the side effects. So repeated aspirations under antibiotic cover. So for that duration of say 1 or 2 months until the active phase settles down, they are called once in 10 days or 2 weeks as per their response for repeated imaging and aspirations under antibiotic cover. I have not, the last 10-12 years, none of my patients have had surgery. Back when I was training at Tata, we used to use something called immunomodulators, Immumod, which we don't get anymore. So there is another herb, a derivative of that called Guduchi. It's called Tinospora cordifolia. It's produced by Himalaya. I think a lot of us now in India, we use that. And I also refrain from using steroids. I've had patients who've been started on steroids, it's been refractory, and then I don't interfere with the treatment. I allow them to taper it, stop, and then I start them again on these immunomodulators, and they've all responded. Albeit, a few of them might take a slightly longer time than the other. I think the maximum was one lady took around 1.5 years or so. But otherwise, within 3 months to 9 months, it all settles. So for me, the very last resort is surgery.
Diptendra sir wanted to make a point.
Now, Dr. Manjula, we have done a lot of work on the immunology of this. Now, what has been proven finally is that now IgM is due to a polymorphism of peripheral prolactin. Now, there are two prolactins. One is the central prolactin, and the other one is called the E-prolactin, which is just like an insulin-like growth factor 1 and 2. They reside on the ducts, and these receptors develop polymorphism. And therefore, there is this antibody reaction. Therefore, it happens. Now, the way doxycycline works, it is a very weak immunomodulator. All antibiotics are weak immunomodulators, and if you use them for a long time, they will have some action. But it's not, if you do a culture sensitivity in IgM, you will always find it negative. Then how is the antibiotic working? It's working as a weak immunomodulator. A steroid is the stronger and methotrexate is the strongest. You are just on the spectrum of using an immunomodulator only.
I think this shows that how much of controversy we have on IgM. So Namrata, Dr. Manjula just said she doesn't use steroids at all. I do use steroids, and so what is your opinion on steroids and immunosuppressive therapy, and when do you start it?
Ma'am, I have seen steroids work wonders on my IgM patients.
Yeah.
In fact, lately I've been using only intralesional steroids. So if they are inflamed, give a course of antibiotic. I usually prefer linezolid, and then simultaneously give an intralesional steroid, and they work like wonders. So usually 1-2 max shots are good enough. Follow up. One very interesting thing, because ma'am, you are from Jharkhand, I am from Jharkhand, Bihar, Jharkhand. Manjula just mentioned Guduchi, that herb. Giloy is the component of that herb, which is freely available in our states. Bihar, Jharkhand mein Giloy is plenty available. So all my patients are told, gaon mein jao, Giloy dundo and drink that juice. We are going back to basics,
Ramdev
but
Baba
which
has
is a
made
very
it
good
available
thing.
also.
Also Texcurmin. So curcumin has a very good anti-inflammatory component as well, and it works wonders in IgM. So those are two things that I love to use for all my IgM patients.
I have no experience on this. However, what the Giloy they are talking about, Ramdev Baba has made it available all across. You can try it. I have no experience on that. And this last question on this role of surgery and with surgery, I think Diptendra sir having the biggest RCT on this, I think I'll give it to him.
Well, as I said, if you look into my study, which I published in the Annals of Surgery, it had 3 arms. Now, there are 3 arms. Arm A was steroid, arm B was wide local excision, and arm C was total duct excision and en bloc removal of the lump and the sinus. So we did not find a single recurrence when you take out the duct as a whole. It's just like simply treating a fistula. It's nothing very complex. If you leave behind the duct and try to excise the lump, you end up nowhere. It is going to come back. Steroid works, probably the duct closes by itself, so it dries up that way. But as I said, as my hairs have grown more gray and I have started using more hair dyes, what I have seen is surgery should be used as the last resort, and that too if you have a unifocal lesion only.
Anand sir, we'll quickly take your opinion on this because, sir, in your study itself, it was mentioned the en bloc duct excision is curative in non-responding cases. So, would you also go ahead with the duct excision or just the lump excision, sir?
Yes, I agree with Dr. Sarkar. Before that, when you plan a treatment, I mean, you have to give certain principles to discuss with the patient. One is that this disease is waxing and waning. Whatever you do, if it goes, patient goes into the remission, this can come back. The second assurance, we have already discussed that you have to rule out at all cost cancer, and you have to assure your patient that you are not suffering from the cancer. The third thing is, Dr. Sarkar has already told that if you do nothing, it will go away. So these three things you have to just tell the patient, and then you start the treatment. Now, I also use intralesional steroids, and the surgery is the last resort, and that I totally agree, and I also do total lump excision with the duct excision.
So
we have the best
these are the
that.
two, systematic review and meta-analysis I have already shown Dr. Sarkar's, and this is another one. And it says that surgical management has high cure rate and low recurrence rate, but further investigation is still suggested. So I would just sum up with that treatment of IGM depends on severity, symptoms, abscess, pregnancy, lactation status, and recurrence. And many of them are self-limiting, as already mentioned by Dr. Diptendra Sarkar. Steroids immunosuppressive therapy can be used in individualized and multidisciplinary approach, and surgery to be done for persistent localized disease refractory to medical treatment. And this was the post-surgical outcome of the patient. So you can see multiple discharging sinus, and this particular patient came up with both sides, so this is her final result. And these are few cases that I have seen in the recent past, and most of them landed up with wide local excision, to be honest. Most of them were diagnosed as Birad's 2 or 3, only one showed Birad's 4. And FNAC was conclusive in 2 of them actually as granulomatous mastitis. So with this I come to the third case, and I don't think I'll be able to go beyond this because we are running short of time, but I would just present a few cases very quickly to have this opinion. 32-year female with bloody nipple discharge, known case of diabetes, hypertension, ultrasound showing dilated ducts, nipple discharge, culture and cytology within normal limits, antibiotics taken, no remind. So MRI done which showed a dilated duct with left intraductal papilloma, microdocectomy done, and it showed intraductal papilloma. So this was a very straightforward case, and in MRI you can see the soft tissue nodule and the excised microdocectomy specimen. Coming to the next spectrum, this is a 14-year girl, obese, with bilateral bloody nipple discharge preceded by pain. It is not related to the menstrual cycle, and she has no history of trauma. She was recently diagnosed with juvenile diabetes, started on insulin. On examination, she had very heavy breast to the tune of hypertrophy and difficult to assess. So an ultrasound as well as a MRI was done. Both were normal. Nipple discharge, cytology, culture and occult blood was done, and occult blood was positive, and the rest was within normal limits. She had multiple such episodes over 1 year, and obviously she was very disturbed. So the challenges in this case would be, what would be the ideal workup for a patient presenting with nipple discharge? We all know that it is triple assessment. However, she did not have any lump. So what would you do? Namrata?
Have you done the ultrasound, ma'am?
Yeah.
The
ultrasound, mammogram, MRI, because she was a very young girl, so we did a MRI.
Ma'am, ideally 14 years old, I would just want to wait and watch on her. Follow
1 year, multiple episodes, psychologically getting very disturbed.
If psychology is the cause, then I'd probably go in for a microdocectomy.
No, but she had bilateral multiple duct bloody nipple discharge.
Still want...
Yeah, please, sir.
I have had 2 such patients. Now, the biggest problem is these young ladies, they start to examine their breast, and what they do is they press their nipple continuously, leading to micro traumas.
Correct.
So the first and the foremost thing is ask them, don't touch your breast, keep it as such, come back to me after 6 months. In my clinic I will press like that. If I find blood, I will take an action, or else it's just micro trauma in the nipple.
Very important message. Google doctors are doing a lot of harm. So knowing about breast cancer, very young girls are coming to this. So, but anyway, any role of hormonal assay or trying to rule out ectopic endometriosis, Dr. Manjula?
I mean, after all the imaging and after obviously giving them all of this advice, I would actually straight away refer her to the endocrinologist to just ensure that there's no, that a hormonal assay is okay. Just in case, because she's 14, she's obese, why does she have a nipple discharge? So, just to be on the safe side.
Anand sir, ductography, ductoscopy, anything?
No.
Okay.
It will not help, and it doesn't help in the nipple discharge. I mean, first thing you have to see, what are the pathological nipple discharges and what are the physiological. If it is bilateral, multiple ducts, and comes on pressure, although it is concerning that this patient has a bloody discharge, if it is not a bloody discharge, they are physiological discharges.
Did you give antibiotics to her?
No. Without proof, no.
Okay, and just one more question because we just have 44 seconds. So is major duct excision appropriate for pathological nipple discharge if we do not find any lesion, Diptendra sir?
Not really.
No.
Not really.
Okay, so with this I would just conclude this session because I have cases but we won't go ahead because I will respect the time. So pathological nipple discharge is defined as fluid that occurs spontaneously and is serosanguinous, serous or watery, and is generally unilateral and arises from a single duct, not multiple ducts. 80% women will have nipple discharge at some time, and they can be caused by intraductal papilloma in 35 to 48% cases, duct ectasia in 17 to 36, and underlying malignancy in 5 to 21. And bloody nipple discharge can occur in adolescent girls as well, and this has been documented in literature. Mammary, I'll just take 30 seconds more. Mammary duct ectasia is the leading cause of bloody nipple discharge. In pregnant ladies, a very interesting thing is that because of increased vascularity and proliferative changes, it can cause unilateral or bilateral physiologic bloody nipple discharge, and this is referred to as rust pipe syndrome. So we should also be aware of this. And it has been proven that we have to differentiate it from the benign, and ductoscopy may have some role, but it is more for unilateral, the single ducts. And major duct excision definitely is not an alternative, because what happens is that most of these lesions will be more than 3 centimeters beyond the nipple you are doing this excision, and the lesions may be much beyond, and especially in childbearing ages, definitely not. What I found was for case reports on bloody nipple discharge in adolescents, most of them were related to juvenile fibroadenoma, intraductal fibroadenoma, and juvenile papillomatosis. And even in children, you might find bloody nipple discharge, and this should be kept in mind that they are all physiological. Dr. Diptendra already mentioned about hyperprolactinemia, so I would definitely do a prolactin level in my patients coming with this. And the only trial I could find was a trial that has been put from AIIMS. Most probably it has been a thesis. It shows phase 4, but results are not available. So this is the flow chart, and I don't have any more time to go ahead with the next section. Maybe next time. Thank you so much. And can I just
Can I make one announcement to everyone? Now, whenever you have a non-bloody discharge, please do ask them how long you are taking pantoprazole and domperidone combination. This is the biggest epidemic in India. You ask a lady, she tells, I have been taking this for 3.5 years. That's the cause of the discharge. Put it off, they will be fine.
So, thank you, sir. So my last message would be that we have very sparse literature on benign breast diseases, and Navneet ma'am is sitting here, so I would ask her that maybe give us more time for benign breast diseases in the ABSI, because there's a lot to do. Thank you.
A profound thank you to our moderator, our panelists, and all chairpersons. That was truly an intellectual feast that challenged our perspective on breast disease. Thank you very much. It's time for the photo session. Kindly come forward, everyone. Moving to the last session, and that is keynote address from our international faculty, Dr. Rishikesh Parameshwar, on the topic of education and training, bridging the gap For this session, I may invite our chairperson, first and foremost, Dr. Shanti Roy, Zordar तालियों से स्वागत कीजिए, and Dr. VP Singh sir. Please join me in welcoming them to the dais with a warm round of applause, ladies and gentlemen. Thank you very much, all delegates. Thank you very much. I request our chairpersons, Dr. VP Singh sir, kindly introduce our next speaker to conduct this session.
Dr. Rishikesh Parmeshwar needs no introduction, son of a soil, and he has been trained from PMCH Patna. The basic training is at PMCH. He was a plastic surgeon, got annoyed, pushed off PMCH and ran to UK with higher degrees, and he's an oncoplastic breast surgeon at NHS there. And now he stands tall against all odds. And here we present you Dr. Rishikesh Parmeshwar with his topic, Education Training Across the Globe. Thank you, sir. Please go ahead.
Thank you. Good evening, everyone, and thanks for the introduction, Dr. Singh. It's always a privilege to come back to Patna, and I don't like this expression of international faculty. It's my home. I come home. And what a privilege to share the dais with Madam Roy. It's a real honor to be on the same dais as Dr. Roy. And we all have looked up to her all these years. She's in fact a teacher of our teachers. So it is really a privilege to be here. I have Dr. Didwania here, and I have to say, I know we are running short of time. I'll try to keep the talk as brief as possible and not exceed the time. But I have to say that it's so nice to see Dr. Didwania. She was the obstetrician to my two sons, and we had such a great care. She is always in our prayer, and my wife remembers all the time. And thank you, madam. Both the kids, they are grown-up adults doing well in their life. So thank you very much. So my talk is about training, bridging the gap. So to understand that, let's just have a look at the current landscape. And I must say, this is not a scientific paper. It is, some facts taken from what we know and my discussion with the colleagues in the UK, as well as a lot of colleagues in this country. So we know that there are an increasing number of oncological surgeons, not as specific to breast, but there's also a problem of low volume breast surgeons, and that has a significance. So that's one thing. There's and 30% of the work is done by people who have just done MS. Well, that's not bad, but that's the reality as to how we cater to such a huge population. And we know the training pathway, and it is evolving. We have now dedicated MCH and endocrinology, and there are fellowship increasing in numbers in many sectors, including private ones. And I'll be failing in my duty not to mention the massive, massive transformation as far as care of breast surgery is concerned, and the credit goes to many of the leaders of ABSIs present in this gathering, and they should be praised and admired for what they have done. I remember coming to India in 2015. That was the first time in ABSI meeting, and the discourse used to be completely different from what it is now. So if you compare that to UK, only 10% of the surgeons are generalists. And by generalist, I mean people who are still doing some kind of general surgery. And 90% of us don't do any general surgery, it's just breast work, that's what we do. And I remember the days when I was training, I was a registrar. Breast wasn't a specialty. People were vascular surgeon doing a bit of breast. People were a colorectal surgeon doing a bit of breast. And the credit goes to Dick Rainsbury, one of the leaders in breast surgery, by creating this oncoplastic, cohort or class of doctors who started doing reconstructive work and oncoplastic work. So that led to increase in the interest, and we can say that breast surgery in the UK is mostly performed by those who are qualified to do. So there's a bit of difference, and that is done through a defined pathway. It is 8 years training, and the final 3 years is dedicated to breast surgery if they want to do breast as a specialty. So to come to the point of what is the gap and how we can address the gap, I think it's good to remind the strengths we have. And it is not one way. I think it is gap both ways. It's not that India has gap, UK has gap as well. And any country for that matter will have gap. So if you look at the strength of Indian conditions, people are trained to do with high volume of complex cases. Generally, they are very resourceful, sentinel node biopsy, doing localization, whatever they think. And I see a lot of people doing a lot of innovative oncoplastic work as well, which is not defined in books. So it is a country of resourceful and innovative people. And people do aspire for excellence. That's one thing which contrasts this country compared to UK, because UK believes in an ethos of a safe, standard care all through. It is not, although the leaders will say, no, we promote excellence, but the fact is it is not geared to strive for excellence. If we have to try to do something new, it takes years to get through the governance process and the managerial approval. So there are a lot of strength in the Indian system. We have the strength in the UK, which I say is not particularly the surgical skill. The organization, the MDTs are proven, and it's proven that it improves outcomes. Regular governance, audits, and those should all be part of the training, and we must consider those things. It is regulated. Some might say it is over-regulated. We have GMC, we have the college, we have the NICE, we have the CQC. Even the mandatory training you do in hospital fire training will have hundreds of regulations and acts. You will get asked, do you know that? So it is in some way over-regulated, service. But those who are training get sufficient number of oncoplastic and reconstructive work. So where is the gap? And now you might differ. This is my opinion, and this is what I think. We have a gap in the UK. Now, I have put gap in the UK first, just to put it in context. I was discussing with a year 7 trainee in a course I conduct run in the UK on chest wall perforator flaps, and there were 2-3 trainees coming, can we go to India to a place where we can get some axillary dissection, because they need to have certain numbers on in their logbook to be signed off. And because we don't do many axillary dissections, and even the newer generation of breast surgeons are de-skilling now. So it is becoming an issue. We don't do LDs. I remember when I joined as a consultant, I used to do 25 LDs a year. I do hardly 5 now. Some years even two or 3. So there are a lot of areas which you see a lot of happening in this country, which is not so in the UK. And as I mentioned earlier, there is a lot of resistance in changing the status quo. There is pressure of cancer waiting times. When you're training, you have a trainee in the theater, but you have 5.5 and 6 cases of cancer to do. And sometimes it limits how much you can allow the trainees to do that. All those, and just to clarify cancer waiting times, we have to get the cancer, although it might sound atrocious in this country, that there is a target of 62 days from referral to first definitive treatment. which might sound a long time, but those are the guidelines there, and we still struggle keeping those 62-day target. And I just mentioned that, how you need to go through several hoops. So if I wanted to do, for example, can I think of robotic surgery or endoscopic mastectomy? It might take me a year or two to just go through this, what we call business case. So you write up, you say that how it is going to help the service, how it is not going to be financially counterproductive, how much time it is going to take in theater. Can we not have a solution which is more cost effective? So all these things you'll need to prove. So it is not that easy. And then there's an impact of reducing working time for trainees. They only work 40 hours a week. And as a trainer, we are not even allowed to say that, oh, do you want to stay a bit longer? So there are a lot of changes which have happened in the recent years. On the other hand, we acknowledge that there is a big rural-urban divide in India. You have tertiary centers, you have big centers doing fantastic work, but there is a lack of that structured care pathway in the rural areas, or even in the tier 1, tier 2 cities. And these are the areas where training should involve from younger age, the organization, the teamwork. Now that doesn't have to be UK or USA team, MDT meeting. It can have its own structure, but the idea is to work in a team where you can speak to each other when you need to. It is an emerging specialty, and I'll say again that ABSI is doing a fantastic job, and they must be congratulated, and the work should continue in that direction so that breast surgery as a specialty or subspecialty is already established in this country is taken forward. So how do we bridge the gap? We identify the gap, as we have discussed, utilize the available resources. I know people think that we need to go somewhere out. I think there's enough resource, there is enough skill, there is enough expertise in this country for people to learn whatever they want to learn. But if you do want to go anywhere, your objectives must be defined in black and white. Why are you going to the UK? We get fellows from ABSI every year, and over the past 5 years, I have hosted more than 10 and it's so gratifying to see that they don't only go for surgical procedures, they appreciate the organization. They see how the one-stop clinic works. They see how the information is given to the patient, how we use the leaflets to the patient, how we communicate with the patient. So they do acknowledge and learn, and I'm really proud to say that all those fellows who have come. But you must have your objectives defined if you go for some kind of short stay observation overseas. And obviously we should have a system where we can continue to collaborate. This is an interesting example of collaboration. This is a paper done by Sanjit, is still here. Training in India and UK with both authors from this country as well as from UK. And basically, you have to start from the basics and then get the message across to the district, the smaller places, the diagnostic, the concept of BCS, the concept of simple angioplastic, and you just get the system working so that people who want to do more complex get the training and can do that in a safe way. There are a lot of models, and these are, one should limit to these models I've just mentioned. And I've already covered that we do get fellows. There are MCH courses, which I'm part of. I'm program director for that MCH course. There are other opportunities, but I must say these courses, these training posts are primarily designed to fill the gaps in the service in the UK. And you must be careful to utilize your time well if you go there, and then choose carefully where you go. On the other hand, we have ABS fellowship for people from UK come for a short-term observership and attachment in India. There is some interest because of these de-skilling of surgeons in the UK in certain areas, and the volume of work in certain aspects going down with de-escalation of surgery. So all these provide an opportunity for people both in India as well as in the UK. So I think I will end by saying that, you know, it is not a rocket science. We all know where the gaps are, so long we are honest and we aspire for the same goals, both in the UK and in India, and for that matter, you know, globally. I think India's global initiatives are, you know, quite appreciable. So it is, the world is a small place, and there is more scope for collaboration than what we think. And I'll end by just highlighting this, something to think, doesn't matter. This is an example of what we are trying to do. It's called GIRFT, get it right first time. And I think that is something we all should be thinking. How do we get the patient treatment right first time? It is a big initiative, and it is one of the things I can say proudly that, you know, they have done very well in the UK. Thank you very much.
Thank you very much, Dr. Rishi. You finished well in time. And sincerely speaking, Dr. Rishikesh has been a pillar for breast oncology across India, and the Indo-UK Forum, he leads the Indo-UK Forum. And if you want to, if you are aspiring for breast surgery, do get in touch with him. The fellowships he was mentioning about, the ABS fellowship, the ABSI fellowship, they are all very important and they are very lucrative. You can have a hands-on directly, you can get in touch with him, and probably you can get benefited. May I request Dr. Shanti ma'am to say a few words?
Thank you, Dr. Padmashree, for such a nice lecture. And actually it was astonishing to see what are the gaps and how you are helping, or you are trying to bridge the gap. You are one of the agents who will help in, and there are so many doctors I saw today that they are trying to bridge the gap between UK and Indian treatment, the method of treatment, the method of diagnosis, the method of how to manage the patients. So bridging the gap is very important, and those who are here, they actually imagine, who haven't gone to UK, they imagine how they are working. Similarly, with such a big population of India, and previously we had limited resources, how we manage our patients. So that is also an example for UK. So bridging the gap is very important, and your lecture was so impressive, and you expressed everything. Thank you so much. Wish you all the best.
Just one line. I get candidates from all over India. Last time in 2024, I had announced that we'll support anyone from Bihar or in this part of the country. If they want to come, we will support, you know, not all, but financially as much as we can. And no one came last time when we announced that kind of support for the fellowship. So do consider if you want to, but you'll have to again have a discussion before you actually decide. So the offer is still there.
So thank you very much. And yeah, Dr. Amar, you want to make a comment?
Just a quick one. So Rishi, fantastic presentation, and having worked in both the systems, I have probably got the best bird's eye view on both sides. And while the training is more structured in the UK, and also they have got various ways of teaching, like MDT setting or proper teaching programs, which we lack in certain aspects in India, we compensate by the number that goes under our hands. And so both sides have got certain advantages and disadvantages. In India, however, we tend to jump on the bandwagon because it's evolving so quickly that we need to slow down here, and UK needs to pick up. Thank you.
Thank you so much.
Thank you very much, Speaker.
Here we come to the end of the session.
Thank you very much, Speaker, and thank you very much. Our
very nice presentation regarding the difference between the two countries. I had the privilege to work in UK long back, 77. Only difference between that, we see many patients we did not see. Hardly, if we take 1/10 of the population or the patient load, they cater. Number two, the system is very good. The working ethos, the maintenance of record, there is unparalleled. And that is the thing, because I work at Multispeciality Hospital, Mortimer Street, London. So I've seen I'm a radiation oncologist, I'm not a surgeon, but the difference between that, the workload is less, they do the very methodical work. Our system does not permit this much of time to give to each patient. That is the difficulty for them, except if you take a special interest. But both the countries has got a place to work each other, because we see more patients than they see in the whole year. Even in 6 months time, you see in our hospital in Patna, Mahavir Cancer Hospital, we see fabulous number of patients unimaginable. I will request you to come and visit to our hospital to see what workload we do every year.
Thank you, sir. Thank you very much, sir. And now we come to the end of the session for today. Now the session is for dinner and some cultural program. Closing remarks.
Thank you very much. It's time for the photo sessions. Kindly come forward, our speaker, and we have reached the end of this program. Thank you all for taking the time to join us and for making today a massive success. The dinner is arranged at backstage area. We request you to join us, and thank you once again. Please enjoy the evening. Dinner followed by musical evening. We have amazing and talented artists over here. So thank you very much. Have a fantastic dinner. Thank you, everyone. Please pay your attention. We will meet tomorrow sharp at 9 o'clock. Morning sharp at 9 o'clock. Be on time, everyone.
Dinner is in the Vatika, just next to this. You have to take the fire exit, or from outside you can enter. It's on the back. You can take the plates, come here, enjoy the musical evening here. Thank you very much. 9 o'clock we are meeting as advised. Thank you.